Good evening, everybody, and welcome to the Foundation for Sarcoidosis Research webinar on managing sarcoidosis treatment and side effects. I'm Mindy Buchanan. I'm the Director of Patient Programs, and I'll be the moderator for today. First, I would like to thank our sponsors for this webinar, Mallinckrodt Pharmaceuticals and aTyr Pharma, for their support of this webinar and our awareness programming throughout the year. Next, I'm going to go through some housekeeping items for everybody. This is a webinar, so we're not able to see or hear audience members. This means if you use the raise hand function, we will not be able to respond. The chat function is available to chat to hosts and panelists. So you can chat directly to us if you'd like to. I will be able to chat with you, the audience, and that's where I'll add any links discussed during the session. And we'll also send out the links in the post-event email as well as a recording of the session. You may send your questions throughout the webinar via the Q&A feature. You have the option of submitting questions anonymously if you prefer. As questions that are answered during the session will filter into the answered questions section, so you can make your choice about whether or not you want that to be anonymous. If you have any technical difficulties, please chat me directly and I'll do what I can to help. It's now my pleasure to introduce for you our experts for today's panel, Drs. Mary A. Willis and Dr. Khatri, and Dr. Krohn is unable to be with us today for the presentation portion, although she may join us for the Q&A session. So do keep that in mind, as Dr. Krohn is our cardiologist panelist today. And Dr. Willis is an associate professor and chair of neurology at one of our FSR Global Sarcoidosis Clinical Alliance founding members, the University of Mississippi Medical Center. She completed clinical neuroimmunology fellowship and previously served as a medical director at the Mellon Center for Multiple Sclerosis at Cleveland Clinic. Her specific areas of interest include medical education, spasticity management, and comprehensive care of the MS patient and neurosarcoidosis. Dr. Khatri is a board certified dermatologist, rheumatologist, and internist, and one of only a handful of triple board certified physicians in the United States. Dr. Khatri is also at one of the FSR Sarcoidosis Global Sarcoidosis Clinical Alliance founding members, Icahn School of Medicine at Mount Sinai in New York, where she previously served as a chief resident. And Dr. Krohn, again, is not likely to be with us tonight. She joined the electrophysiology group at one of our FSR Global Sarcoidosis Clinical Alliance founding members, Virginia Commonwealth University, at the Poly Heart Center in 2008 as assistant professor of internal medicine and cardiology. With that, I welcome Dr. Willis to begin her session.
Thank you, and thank you for having me here. Give me just a second to try to share my screen here. Right, you guys should be able to see my screen. I'm happy to be here and grateful to FSR for the opportunity to talk about neurosarcoidosis. My experience has been that many of my patients go years without having a diagnosis, even though they've had neurologic symptoms and may have seen neurologists and various other care providers for a few years. So I thought we should start with the basics of neurosarcoidosis. It's not very common to have neurosarcoidosis, so granulomatous involvement of the disease within the nervous system. It happens in about 5 to 10% of patients with systemic sarcoidosis, so with pulmonary sarcoid or GI sarcoid or ocular sarcoid. Although the asterisk is here because some autopsy studies suggest that there are actually more people with neuro involvement of sarcoid than the people that we know are symptomatic. Isolated neurosarcoidosis is very rare. This happens less than 1 to 2% of the time. And very often when we see these patients with what appears to be isolated neurosarcoidosis, they develop systemic symptoms later on. Neurosymptoms can be present at the time of the diagnosis. So if you have pulmonary sarcoid, you may have had neurosarcoid at the same time, or the symptoms can develop later, but it usually develops pretty early in the course of sarcoidosis. So very often within the first 2 to 3 years after diagnosis, whatever organ system was the first one involved. It's important to remember that not all neurosymptoms equal neurosarcoidosis. Some of you have already submitted questions that are related to this. I mean, we can see neurosymptoms as side effects of medications sometimes. And then sometimes neurosymptoms just result from other medical conditions that someone has. For example, there are many, many causes of fatigue, and that doesn't always mean that someone has neurosarcoidosis. Any part of the nervous system can be involved. So we can see involvement of the nerve that goes to the back of the eye called the optic nerve, the brain, the spinal cord, the long nerves called peripheral nerves after they've left the spinal cord, the small fiber nerves can be involved. And we can also see a type of nerve involvement called autonomic nerves. And these are nerves that control heart rate, blood pressure, sweating, even the GI motility or the movement of stool. So how often do we see these particular presentations of neurosarcoidosis? The most common presentation when someone has neurosarcoidosis is a cranial neuropathy. This means there's a problem with one of the cranial nerves, and most of the cranial nerves involve the head. The most common cranial neuropathy that we see is actually a facial droop that looks like a Bell's palsy. So if someone has a Bell's palsy, one of the things that I always think about if it's a recurrent Bell's palsy is the possibility that they have neurosarcoidosis. Headache is also a common presenting symptom, seizures, meningitis. We can see people with a variety of walking difficulties, numbness. Paresthesias means tingling or abnormal sensations. I would group pain into this, although I think the frequency of pain in neurosarcoidosis and sarcoidosis in general is probably higher than what you see here in this table. Of course, we can see weakness. We can see hormone problems that are related to involvement of the centers of the brain that control hormone function. Fatigue and cognitive impairment are also very common presenting symptoms. Because the symptoms can look like anything, it's a challenge to diagnose neurosarcoidosis. There are some studies that can be helpful and a set of criteria that we use to try to diagnose neurosarcoidosis with as much certainty as possible. Of course, the best way to confirm that what we're dealing with is actually neurosarcoidosis would be a biopsy, but we very rarely biopsy the brain or biopsy a peripheral nerve unless there's no other way to get the right answer. So if someone has symptoms consistent with neurosarcoidosis, they have an MRI that looks like sarcoid, there's a specific CSF profile that really is very suggestive of sarcoid, or if we see EMG, these are electrical findings that would be typical of sarcoidosis, then we can say with either possible, probable, or definite certainty that what we're dealing with is neurosarcoidosis and not something else like an infection or lymphoma or some of the other things that can cause many of the same symptoms and imaging findings as sarcoid. Once we've made the diagnosis, there are a number of different treatment options. Most of you know that we start with steroids. No matter which organ system is involved, steroids are a good starting point because steroids work very quickly. But we try to avoid long-term use of steroids as much as possible. Long-term use of steroids carries risk for weight gain, diabetes, bone thinning. We can see something called avascular necrosis, which is a decrease in blood supply, usually to the hips or the shoulders develop with long-term steroid use. So there are a number of problems that we can see with long-term steroid use, whether we're talking about prednisone or dexamethasone. So if we expect someone to be on a steroid for more than a year, very often we'll start a steroid sparing agent. These are things that you may have heard of already. So azathioprine or Imuran is a common agent that's used. Methotrexate, mycophenolate mofetil, cyclophosphamide, rituximab, and cyclophosphamide have been used in case series in patients with neurosarcoidosis. There are larger case series and cohorts with azathioprine, methotrexate, and mycophenolate or Cellcept. So those are the ones that most neurologists are going to be familiar with. And then there are agents that are really up and coming in the use for neurosarcoidosis. Certainly sarcoid centers of excellence use these medications very frequently. Infliximab and adalimumab are commonly used for rheumatologic conditions, but we're using them more and more for patients with neurosarcoid. Each one of these medications has a different set of side effects, which we'll talk about a little bit more in response to your questions. And each one has a different set of monitoring requirements. So how do we decide which one to go with? We don't have any randomized controlled trial data. This is such a rare entity that it would take years and years to actually have a clinical trial to study which medication is superior in neurosarcoidosis or not. So right now it's based on expert consensus and in the approach to treatment of neurosarcoid. And most patients, most providers who treat a large amount of neurosarcoid will kind of divide their algorithm into mild, moderate, and severe. With someone having difficulty walking because of spinal cord involvement being in the category of severe, and someone with maybe a little bit of vision loss that gets better quickly with steroids to be in the mild category, and moderate is a much wider range. And the common thread is that the initial treatment would be a steroid, usually either prednisone or an IV form called methylprednisolone. And if things get better, we may just try to slowly wean the steroid, or we may add a second agent, one of the pills that I mentioned, or if it's very severe, we may go straight to infliximab. So this is just a general algorithm that's based on expert consensus. And of course, we have to tailor this to the individual person, and we have to consider what other organs are involved. Not all organs affected by sarcoid respond the same way as neurosarcoid. So, for example, mycophenolate mofetil works better for neurosarcoid than it does for some other forms of sarcoidosis. Hydroxychloroquine was not on the table that I showed you because it doesn't work very well for neurosarcoid, but as you'll hear from Dr. Khatri, it does potentially have some efficacy for other forms of sarcoidosis. So with that, I'm going to turn things over to Dr. Khatri to talk about cutaneous manifestations of sarcoidosis.
Hi, I'm going to share my screen. Okay, share. So Mindy, I can't start my video because it says that the host has stopped it.
Oh, sorry. Yeah, let me fix that for you. That should help.
Okay, yeah. Excellent. I'm assuming everybody can see this. And Mindy, kudos to you for saying my name, pronouncing it correctly. It's a tongue twister. So I will be talking about cutaneous sarcoidosis today. Hold on, let's get this. Sorry, this is a slightly graphic image, but this is just to sort of drive home the point that for the most part, lesions of sarcoid are these bumpy, flat, annular patches or plaques. They can be papules, which are smaller in size. So I'm going to get my laser pointer. So you can have small lesions, you can sort of have larger widespread lesions. And this certainly is a patient with cutaneous sarcoid who has extensive cutaneous sarcoidosis. So this was just like an image of a sort of a typical sarcoid patient that I would see in my practice. In terms of diagnosis, it can be a great mimicker. Oops. So doing a skin biopsy to diagnosing sarcoidosis is really the way to go. And what you see is that this is a dermal process. So this is our epidermis and this is our dermis. And you see what is called naked granuloma. So you're kind of looking for this, which are these giant cells, and they really don't have much in terms of inflammation around it. So this is how you diagnose cutaneous sarcoidosis or sarcoidosis affecting the skin. It's a pretty common organ involvement, and it has been described in about 25 to 33% of patients with sarcoidosis. Just only cutaneous involvement is rare, and it's seen in just 4 to 5% patients, just based on the published data out there. So what this really means for our patients with sarcoidosis is that if they're presenting to me with skin findings, and I'm like the first point of contact for them, it behooves me to make sure that they are seeing other specialists to rule out other organ involvement, because very rarely will they just have skin involvement in the absence of any other organ involvement. So all my sarcoidosis patients see a pulmonologist and they see an ophthalmologist, and that's like the bare minimum, right? And this is important. And the other thing to know is as well that 25% of patients have, skin lesions prior to systemic organ involvement. So that sort of is important, because from a patient perspective, if you're going to a dermatologist with this lesion on your skin that gets biopsied, comes back as sarcoidosis, make sure that you get referred out to specialists, such as a pulmonologist, definitely an ophthalmologist. And if, as a part of like the whole, you should have an echocardiogram as well. And then again, see a cardiologist if there are any changes on the echocardiogram. So it's important to get those referrals or be an advocate for yourself. Right. The other thing that's important to know is that the cutaneous lesions of sarcoidosis, they look very varied. So that image that I showed you a slide or two ago is not necessarily what every sarcoid patient's sarcoid on the skin will look like. So sarcoidosis comes in various clinical phenotypes on the skin. And that's why in dermatology, we really call it the great mimicker. So for the most part, any dermatologist that you see should or will get a skin biopsy to diagnose sarcoidosis. Certainly, if there is a clinical suspicion, or if there is just a solitary lesion and they don't know what, a biopsy is certainly diagnostic. Okay. You've heard a lot about treatment options, from a neurosarcoid perspective. So there's certainly a lot of overlap when it comes to treating cutaneous sarcoid. So most of the drugs that are used for other organ involvement are certainly used for skin or cutaneous sarcoidosis. The important thing is that there's no FDA-approved treatments for cutaneous sarcoidosis. As was mentioned earlier, steroids are really the first line in treating cutaneous sarcoidosis as well. I didn't talk about topicals here. Certainly, those of you in the audience who've had skin sarcoidosis and have gone to a dermatologist probably got, topical steroid or something that's a steroid-sparing topical. But really, those medications are not that efficacious in treating cutaneous sarcoidosis because, as I'd shown previously, the lesion or the pathology is in the dermis. So absorption of anything that you're putting topically on the skin, it's a little harder. Certainly, they can be used as adjuncts, but in itself, they are not efficacious. And this is for topicals. So that's an important thing to know. The other thing that, dermatologists do as well is injecting steroid into sarcoidosis lesions. And that works because, you're sort of delivering the medication where it needs to go. It's fine to do that for a few lesions, but if you have generalized cutaneous sarcoidosis, as was in the first image that I showed you, then you're looking at something that's systemic. Methotrexate, azathioprine, hydroxychloroquine, or TNF inhibitors have been used successfully in treating cutaneous sarcoidosis, and often in combination with steroids. So certainly there's like an overlap when it comes to treatment. I was also supposed to talk a smidge about sort of the side effects of these medications that we use for cutaneous sarcoidosis. Of course, the list is not by any means exhaustive, but this is sort of the important side effects that can be seen when you're using oral immune suppressants. So you can have bone marrow suppression, there's these medications like methotrexate, azathioprine, Cellcept are suppressing your immune system. So certainly there's an increased risk of infection. Patients can have GI side effects, fetal toxicity. So of course you cannot give it to somebody who is pregnant or planning on being pregnant. Certainly sort of a little shout out for azathioprine. From a derm perspective, we don't like azathioprine that much because of all immune suppressants out there. There's data that's published which shows that azathioprine certainly has the highest risk of skin cancer. So always good to know because if I have a patient who has cutaneous sarcoidosis, who also has, a personal history of, multiple skin cancers, I sort of stay away from azathioprine unless, of course, it's sort of the last resort. Right. Again, just to say that this side effect profile is not by any means comprehensive, or this is just sort of, I just picked up the main ones in terms of AEs. Okay. Long story short, there's a significant unmet medical need in the treatment of sarcoidosis, and I'm speaking this from like a cutaneous sarcoidosis perspective. it was mentioned that anti-TNFs are used for neurosarcoidosis. So we also use anti-TNFs such as adalimumab, infliximab, and these might be names that you're familiar with. We use them to treat generalized cutaneous sarcoidosis. And then certainly there's a robust published data in the cutaneous sarcoidosis realm with regards to the efficacy of anti-TNFs. And really adalimumab, which is the brand of which is Humira, and infliximab, again, the brand is Remicade, are the two anti-TNFs that really have the most robust data when it comes to cutaneous sarcoidosis, robust data and efficacious data. This is just like a package insert straight from adalimumab, and this is not unique to adalimumab, but more of like a class effect of anti-TNFs. Again, they're strong immune suppressants. So if any of you are on it, you might have read the package insert, and it kind of reads like this long book. It'll talk about infections, it'll talk about malignancy, it'll talk about neurological reactions that can happen, congestive cardiac failure, patients can't take anti-TNFs. So it's, it does have a laundry list of side effects, and certainly a good history taking is important. Knowing what comorbid conditions patients have is important before we decide on a therapeutic intervention. And again, this is just another published article that was published from a French cohort looking at the efficacy of anti-TNF block agents, and sort of repeated the same thing, that they are very efficacious for cutaneous sarcoidosis. So, long story short, the data for cutaneous really says steroids are the first step or the initial treatment. If they have failed, you can think of second line immune suppressives such as methotrexate, azathioprine, mycophenolate. They certainly also mentioned leflunomide, which is called Arava as well. So that can be considered as well. And then the third line is biologics or other agents. And this by no means is a very comprehensive sort of treatment paradigm, but this is just to give an idea of what the process is when it comes to thinking of sarcoidosis. There are new developments in the area of sarcoidosis. Some of you might have seen advertisements of JAK inhibitors, such as Rinvoq or Xeljanz. So JAK inhibition has shown to play a role in cutaneous sarcoidosis. So there is published literature that talks about using JAK kinase inhibitors to treat cutaneous sarcoidosis. So this is just a case series that was published a few years ago. Again, JAK inhibitors have a laundry list of side effects. They do have a big black box warning, which talks about malignancy and cardiovascular events. So again, this is a conversation to be had, and not, it's a risk benefit analysis. But JAK inhibitors they seem to be the next frontier, certainly from a cutaneous sarcoidosis perspective in terms of therapeutic intervention. And I think that's my last slide. So I will, so that was the last slide.
Great. Thank you so much, Dr. Khatri and Dr. Willis. I am going to switch the screen so that we're all on the screen together. Just as a reminder, folks, if you have your hand raised, we can't get you, but if you want to put your question in the Q&A, that would be great, so that we can answer that for you. We do have a lot of time for Q&A. Both Dr. Willis and Dr. Khatri have made sure to support the Q&A here today. I'm just going to help stop Dr. Khatri, are you able to stop your screen share? Oh, there we go. Yes, excellent. All right. Well, thank you again for those great presentations. We do have some questions already in the Q&A session. We actually have one in the chat. So let's see. One of our patients, their doctor wants them to switch from Remicade to Humira. They've been on Remicade since March. They've relief from fatigue since July and August. They have bone sarc and small fiber neuropathy. Any comments on the pros and cons of making that switch? We can start with Dr. Willis.
Yeah, I guess I can go first. You know, in terms of Remicade, which is also known as infliximab, and Humira, which is also known as adalimumab, they work in the body very similarly. They belong to that class of anti-TNF agents that Dr. Khatri was talking about. Remicade is given as an infusion, and there are other brand forms of infliximab. So Remicade is not the only one, but they're all given in infusion form. Humira, on the other hand, is usually an injection. So one of the reasons that we may consider a switch from Remicade to Humira is someone having infusion reactions with Remicade. Sometimes they don't have those reactions, which could be headaches, it could be joint pain, muscle pain that occur with the infusion. Sometimes they don't have that when they switch to Humira. So that would be one of the reasons that I, as a treating physician, might recommend that someone make that switch. Another reason is that sometimes when we're monitoring for sarcoid activity, we get an indication that the medicine isn't working quite as well as it did initially. And this can happen for a variety of reasons. With Remicade or infliximab, your body can become immune to it, so to speak. You can begin making antibodies to the infliximab. And if you switch to a different anti-TNF agent, you may get back the same effect that you initially had from the Remicade. So that's how I think about recommending someone make a switch from one TNF agent to another TNF agent.
Great, thank you, Dr. Wills. Dr. Khatri, do you have anything to add to that?
Right. So, every patient is different. For Jackie, who says that she's on Remicade and she's had improvement in some symptoms of sarcoidosis, the question is, have you overall seen an improvement compared to baseline when you were not on Remicade? Or did you have an initial improvement and now you've sort of plateaued, or your improvement that you made is not as robust or consistent or durable anymore? So those can be clues for us as physicians to decide whether the Remicade is continuing to show efficacy, because you might have a primary response, but you can have a secondary loss of efficacy, which just means that the drug worked for a bit and it's not really working good enough, or it's not continuing to show robust efficacy. So that could be a reason why her physician is thinking of a switch. And I certainly agree with Dr. Willis that staying, switching within the same class can be done even though you're losing efficacy to Remicade. So certainly in my practice, if I've done a switch from Remicade to Humira, I've had patients capture response and vice versa.
Great, thank you. So you guys both mentioned that prednisone or corticosteroids are first-line treatments very often. We do have a question about from someone who's newly diagnosed. Are there things they can do to prepare for taking, a higher dose of steroids? Are there things they can do in advance or as they're newly starting on to that drug?
I can take a stab at it first. So the question is, how high a dose of steroid are we thinking of? And then, if you're looking at 1 milligram per kg body weight, which could be 60 milligrams or above per day, certainly a higher dose of steroid for long periods of time will have greater side effects than a lower dose of steroid for shorter periods of time. So certainly in patients that are on high dose of steroids for long periods of time, we start adding calcium, vitamin D as like a form of protection against, osteopenia, osteoporosis. If it's a postmenopausal woman who has a bone density that shows osteopenia or osteoporosis, we obviously treat that with bisphosphonates if they're on high dose steroids. Depending on risk, pneumocystis carinii pneumonia, I know the name has changed. Sometimes Bactrim prophylaxis to prevent that when you're on high dose steroid is done as well. The third thing that comes to mind is GI side effects, because, when you're taking high dose steroids, you can have GI side effects. So physicians often add, proton pump inhibitor like Pepcid or a H2 blocker like ranitidine to the mix to sort of offset the gastrointestinal side effects. So those are things that we do to decrease or minimize side effects. But this doesn't mean that we can minimize all side effects. Some patients have steroid psychosis at high doses of steroid. And then I shouldn't just say that high dose can do that. If you're extremely sensitive to steroids, you can have that certainly at a lower dose. So that's just something to be aware of. Certainly, Dr. Willis can chime in if there's any way to prevent that side effect, which I don't know of.
Yeah, I mean, first, I would reassure you in starting steroids that although we list a long possibility of side effects, either immediately or long-term, most people tolerate these medications very, very well. And initiating steroids makes them feel much better than they felt when the sarcoid was not treated. So keep that in mind. Although we can list a number of possible ways that you might not feel well, the majority of people tolerate steroids very well. There are people who are sensitive to medications, and that sensitivity can be at various doses, just like Dr. Khatri said. It could be at as little as 5 milligrams of prednisone, or it could happen at 60 milligrams. So it's hard to predict in an individual person. I would say that if you are getting started on an IV form, so we very often use IV steroids to get someone started before beginning the daily prednisone pills. One thing that you should expect when you go for that infusion is that as the medicine is going in, you'll get a metallic taste in your mouth. That can be prevented by some hard candy. It goes away after the infusion. Many people, whether they're starting with the IV form or a high dose prednisone, may initially experience some insomnia, some sleep disruption when you're getting started on the steroids. I usually recommend that people start with Benadryl before going on a prescription medicine to help with sleep. That initial insomnia for many people levels out so that you don't need something to help you go to sleep, but that is something that you may prepare for going into it and have something on hand to help you go to sleep the first few nights. Weight gain can happen, and the distribution of the weight is what's concerning to a lot of people when they're on prednisone. The weight gain is in unusual places. So if you would normally gain weight in your belly, with the steroid, weight gain can be in your face. It can be on just behind your neck. So it can be in places that would not normally be if you gained weight. So the way to prevent this is really to pay attention to the calories that you're taking in. So the steroids will increase your appetite. They also change your metabolism. So making sure that you're watching your calorie intake, staying away from high carbohydrate foods will help reduce that weight gain associated with the prednisone.
Great. Thank you, Dr. Willis. So we have a question about due to the laundry list of different side effects that come from the many different kinds of medications patients might be on, how do you determine which side effects are kind of owned by what? What's sarcoidosis? What's the side effect of X medication versus other medications? How do you guys sort that out? Dr. Willis, we'll start with you, and then Dr. Khatri, if you want to add anything there.
Sure, I love that question, and it's one of the most common dilemmas that I face in practice. Many people with neurosarcoidosis are on a long list of medications, not just their immune medicines that we use to manage the sarcoid, but also medicines to help manage the symptoms associated with their neurosarcoid. So, for example, someone with small fiber neuropathy might be on an immune medicine, but they're also on medicines to help with nerve pain. And it can be difficult to figure out which medicine is the culprit, which medicine is contributing, for example, to brain fog or increased fatigue. So the strategy that I use is the medications that are not essential, we can take those off one by one until we see what was actually the culprit. It's very, I try not to change the immune therapy first if it's working. So if someone's immune treatment has been working to control the neurosarcoid, I don't want the neurosarcoid to reactivate. So it's much easier, and it makes more sense to me to try eliminating some of those symptom medicines first that aren't absolutely necessary.
Great, thank you, Dr. Willis. Dr. Khatri.
Right. So I will say from a skin perspective, I'm a little bit more fortunate because, I generally my sarcoidosis patients are on one drug and that's it. But one of the questions that I asked my patients are is this new that started after you started this new medication, or was it there before I started you on this new medication. And that sort of helps me tease out whether it's the drug that's doing it, or if it was a disease that was doing it before the patient was put on this medication. And then I do agree with with what Dr. Willer said, that if there are multiple medications, stopping one, seeing if symptoms abate, and if that's not the culprit, then restarting it is helpful.
Great, thank you. There are so many good questions coming in, guys. I know I'm trying to orient some of these questions in groups so that we kind of get on a little bit of a topic and then we'll move to another topic. Is there a medication? We got this question multiple times in the registration. Is there a medication if you have systemic sarcoidosis that is best or works best for lots of different organ manifestations, or not? We can start. Dr. Khatri, why don't you start?
Right. So the answer is that, certainly anti-TNFs do work for a lot of manifestations of sarcoidosis. They have very robust data. And again, this is not data from clinical trials. These are data from this is data from case series, case reports, and things of that nature, or analysis of databases, such as what was done in France. So for cutaneous sarcoidosis, for arthropathy from sarcoidosis, and from a pulmonary sarcoidosis, anti-TNFs do have efficacy, and it's like multi-organ efficacy. So that's certainly something that can be considered in a patient that has multiple end organ involvement from sarcoidosis. I will let Dr. Willis talk about neuro, because that is not something that I know. But then, to some degree, CellCept, methotrexate, azathioprine also are robust in treating multiple organ involvement in sarcoidosis, because they are sort of dampening the immune system. And that's really what you want, because, sarcoidosis is an autoimmune disease where your immune system is sort of out of control. And most, if not all of these oral medications are sort of generally dampening the immune system. So they will have, efficacy in different domains of involvement.
I agree with Dr. Khatri. There's not one medication that we can go to and say, it doesn't matter what kind of sarcoid you have, we're going to put you on this medicine. So that doesn't exist as we know it right now, although with FSR's help, we may get there in the future. So when I think about someone with neurosarcoid and they also have, for example, lung involvement or sinus involvement. Sinus involvement actually responds very well to leflunomide, also known as Arava. But one of the side effects of leflunomide is a peripheral neuropathy. So if someone is already having nerve symptoms, I actually don't want them to use that medication. So, I think the variability in the response among individuals who have sarcoid and the different combinations of organ involvement that we see really emphasize the importance of having a care team. Just like Dr. Khatri said, if you have skin sarcoid, you also need to have a lung doctor evaluate you for pulmonary sarcoidosis, and you may need to have other people involved in your care team. And it's very helpful if they're communicating with each other, because each one is going to look at management of your sarcoid just a little bit differently.
Great, thank you very much. So we did have a question. I know, Dr. Willis, you mentioned Benadryl. So we have a couple questions, 2 questions about Benadryl, actually. So if you're not on any other medications and you're having difficulty sleeping and melatonin has not been helpful, is Benadryl an option for helping you get to sleep on a regular basis? I think is the question, like a usual use.
Yeah, I mean, it's best if you're not using something every night to help you get to sleep. But in terms of medications, if you are going to use something on a regular basis, Benadryl, which is also known as diphenhydramine, and there are a number of other over-the-counter antihistamines. That's the group of medicines that it belongs to. Those are safer to use long-term than medications like one you may be familiar with is called Ambien. There are also medications called benzodiazepines, things like Valium, Xanax, Ativan. Daily use of those medications actually disrupts the sleep cycle and can lead to long-term cognitive trouble. So we try to avoid those medications if someone can get good sleep with just a little bit of Benadryl before bedtime.
Great, thank you. So we have a couple questions about how safe. I'm going to give two different medications. We got the same question. How safe is long-term use of CellCept? How safe is long-term use of methotrexate? Dr. Khatri, why don't we start with you?
Right. So it's a risk benefit analysis in some ways. Sarcoidosis is a chronic disease. And whether it's CellCept or if it's methotrexate and they're working for you, and as long as they're not, your kidney functions, your liver enzymes, your hemoglobin levels, hemoglobin white cells and platelet levels are stable, they're not dropping or elevation for kidneys and liver, it's safe to be on indefinitely, as long as the drug is working for your disease and you're not having side effects.
I agree with Dr. Khatri. We don't have a lot of data with long-term use of these medications in sarcoidosis. We do have some data on long-term use of methotrexate and mycophenolate, for example, in rheumatologic conditions, in inflammatory bowel disease. And what we see is exactly what Dr. Khatri mentioned. I mean, it's the risk of long-term use resulting in cancer is much lower than the risk associated with poor control of whatever disease it's treating. So the risk of untreated sarcoidosis, if you need that medication to keep your lung sarcoid under control, for example, or your neurosarcoid, the risk of permanent tissue damage really is higher than the risk of malignancy, which is cancer or infection associated with long-term use of the medicines.
Great, thank you both. So we have one question about, so we have a patient who's been diagnosed with pulmonary sarcoidosis. They're treated by a pulmonologist. They were negative for cardiac sarcoidosis, but they have a question around whether or not sarcoidosis can affect balance issues. And if so, I guess the follow-up question that would be, if so, what would be their next step in terms of, would they need to seek out another specialist potentially, or go to their pulmonologist with that?
So I'll take the first shot at that. Balance is usually something that falls in my domain, and it's a symptom that does not always mean someone has neurosarcoid. Some of the medications that we use to treat sarcoidosis and really other conditions in general can cause a neuropathy that results in balance trouble. We can also see vitamin deficiencies that may be a consequence of your systemic sarcoid that result in balance problems. So there are a number of different things that could cause imbalance. And I do think that you should talk to whoever is leading your care, whether it's your family doctor, your pulmonologist, whoever it is. If you're noticing that you have balance trouble, absolutely bring that up, and a neurologist would be the person that you need to see for evaluation.
Great, thank you. Dr. Khatri, we have a question about biopsies and understanding if you have sarcoidosis. Would a dermatologist have to know to look for sarcoid during a biopsy, or would the biopsy present the sarcoid just by getting the biopsy on its own?
Right. So sarcoidosis has a very unique finding, which is those granulomas in the dermis that I showed you. So even if, say, the dermatologist who does a biopsy does not think of sarcoidosis in his or her rule out, which then goes to the dermatopathologist, it is easily seen on a skin biopsy if the sample is right. So that's the caveat that I will say, that if it's if it's the actual lesion that's being biopsied and not just normal skin, then diagnosing sarcoidosis, even if the dermatologist has not specifically asked for it, is not hard to do, because it has a unique appearance under a microscope. Certainly, there are other conditions which make granulomas, but naked granulomas, which means those giant cells without inflammation, are pretty unique to sarcoidosis. So in the right clinical context, putting that derm path puzzle will make sense.
Great, thank you. We have a question about whether or not there are any new trials for neurosarcoidosis. Dr. Willis, I'll send that off to you.
Sure. There are a few ongoing trials for neurosarcoidosis. Most of these are very small, and they involve a single center. There are a few that are multi-site trials. Things that are being considered are B-cell therapies. I mentioned something called rituximab. That's a common B-cell therapy. What spurred those clinical trials was individual case reports of people with neurosarcoid responding after they had failed TNF agents. There are a few ongoing studies looking at a different type of steroid called Acthar gel, for initiation of treatment rather than maintenance of treatment. So there are a number of things that are in the works for neurosarcoidosis. And a good way, if you're really interested in finding clinical trials that you could be a part of, a good resource for that is a site called clinicaltrials.gov if you want to see if there's something close to you.
Great, thank you, Dr. Willis. I'll add to that to find clinical trials. FSR does have a clinical trial finder on our website. I'll add that link in the chat at some point and make sure you guys get it in the email. We also have a patient registry where if you complete the patient registry, we do send out alerts about new clinical trials when we have information on them, and you potentially meet the eligibility criteria by what you completed in the registry information. So definitely lots of ways to find clinical trials. Between clinicaltrials.gov and FSR's website is a resource too. So thank you very much. So we have a question about infliximab for neurosarcoidosis. So one of our questions is they have a rheumatologist that says they'll never get off of it, and the neurologist says that they can. Since we have a rheumatologist and a neurologist here today, are there any indications for going on or off infliximab specifically?
From a neurosarcoid standpoint, it really depends on how severe the neurosarcoid was before someone began treatment, as far as the likelihood that someone can come off eventually. The other is consideration of the reasons that someone would want to come off of infliximab, if it's to decrease the infusion burden or potentially avoid some of the side effects that go with the infliximab, or because of its cost. We can switch to a different immunotherapy when the sarcoid is in remission, and we may be able to get someone off of infliximab. The concern with severe neurosymptoms that require treatment with infliximab, which is usually given as the third medicine, is a risk for rebound in disease activity or risk of recurrence. And so we're still trying to build evidence to know who is at high risk for recurrence. But at this point, it seems to be the people with most severe disease and hardest to control initially are at higher risk and thus less likely to come off of infliximab.
Great, thank you, Dr. Willis. Dr. Khatri, do you have anything to add to that one?
So just to sort of agree with what Dr. Willis said, that if your disease is active, then you need to stay on the drug. And that could mean months, years till you go into remission. And even I think once you're sort of clinically in remission, there's always this concern, if you stop treatment, can things relapse? And then the problem that comes with anti-TNFs is that if you stop, restart, you build, in just lay terms, tolerance to it the second time or the third time around. So, it's not an easy answer, like, one size fits all. It really comes down to, if your disease is active, you need to stay on it. If you go into remission, if you consider stopping it, there is a theoretical risk of relapse. And there is a theoretical risk that once you are put back on the infliximab, the response will not be as robust. So it's really it's a three-way conversation between patient, the rheumatologist, and the neurologist to sort of decide what is the right approach.
Great, thank you both. We have a question about whether or not age influences treatment decisions in terms of some of these other drugs. Dr. Khatri, we'll start with you since you're off mute.
Right. So treating a patient with sarcoidosis, we obviously as physicians take into account, what are the comorbid conditions that you have. I wouldn't really necessarily say age comes into play, but, if you're an older patient, maybe you have more comorbid conditions than somebody who's younger. That's not always the case. So it comes down to comorbid health conditions as opposed to like a finite age range. Really, it isn't. So I would say age does not play a role. Where it can be an issue is with regards to side effects of medication. Older patients might be a little bit more sensitive to systemic immune suppressants as opposed to somebody who's a little younger. So those are like the two things that I would point out when it comes to age and sarcoidosis and treatment.
I agree with that, and I wanted to give a further example of how comorbid conditions may influence the treatment decision. And if someone already has diabetes and it's diabetes that's difficult to control, we'll want to minimize the amount and the duration of the prednisone, which can make the blood sugar even harder to control and then cause other health problems to develop. So we may be more aggressive about the immune therapy that we use in someone who has diabetes that's been difficult to control, just as an example. And then, as Dr. Khatri said, the impact of age for me really influences recommendations for vaccinations, recommendations, or my thoughts as far as screening tests to make sure that someone is immune to viral infections, and their vaccination status is really good. So we know that for some vaccines, that status can wane as someone ages, and I may delay treatment just a little bit to go ahead and get someone vaccinated before starting on an immune therapy. But really, for me, it's really more the comorbid conditions that someone has.
Great, thank you both very much. So we have a couple questions about protection and helping out some side effects. So the first question is about whether or not there's anything you can do to sort of help the liver function if you're taking certain medications. This patient has had neurosarcoidosis for 5 years and they've got multiple medications. And then the next question actually is whether or not there's anything to do for if your medication is making you constipated. So those are the two questions about kind of management side effects there.
Okay, I'll start. So in terms of managing liver impact of the medication, many of the immune medicines that we've talked about do have some components of their metabolism through the liver. As a clinician, I try to minimize other medications that might have that same processing. You can always ask your pharmacist for a review of the medicine. So where you go to pick up your prescriptions, your pharmacist can also give you an idea if you want to know which of these medicines go through the liver and which ones don't. And maybe you didn't ask your doctor, you didn't get an answer. Your pharmacist can always review those. But as a clinician, I try to minimize the number of medicines that go through the liver. From another lifestyle standpoint, reducing alcohol use and reducing tobacco use, eliminating them if you can, actually helps protect the liver. Making sure that you're minimizing acetaminophen or Tylenol, which is an over-the-counter medicine that is metabolized by the liver, is also really important. As far as medications causing constipation, this is a very common problem, and it can sometimes be challenging to figure out which medication is the one doing it. So I take the same approach that I mentioned earlier. If there's a medicine that someone doesn't need and may be causing the constipation, usually a few days to a week off that medication is going to give you the answer that you need, whether it was the culprit. And if we can't figure out what it is, or if all of the medications are absolutely necessary to control someone's symptoms and their disease, there are a number of strategies that we can use to make sure that the bowel movements stay regular.
Great, thank you. Dr. Khatri, for cutaneous manifestations on the face, could there be any efficacy in seeing an esthetician for laser therapies, needling, peels, or surgical removals of lesions?
So I will say this, please do not ever see an esthetician. If you have sarcoidosis on your face, you want to see a board certified dermatologist, because they would have had more experience compared to an esthetician when it comes to treating, cutaneous sarcoidosis, right, on the face. So the data for using lasers is not very robust. There are some publications that have sort of looked into it. There was a case report of having used PDL, which is pulse dye laser, along with systemic therapy for sarcoidosis, which was beneficial to a patient. There are some studies looking at, I'm going to sort of rattle out names of lasers, but then there is a YAG laser, which has been used to look at, to treat cutaneous sarcoidosis. There's been Q-switched ruby laser. So what I will say, long story short, is that please see a physician, a dermatologist, and one who has experience in lasers and or has experience treating cutaneous sarcoidosis, as opposed to an esthetician. And then it doesn't take away from the fact that you'd have to be on something systemically for your sarcoidosis, and using laser is sort of an adjunct. just to improve the appearance of lesions on the face.
Great, thank you. So Dr. Willis, how does a clinician test for small fiber neuropathy? And then does having small fiber neuropathy make a patient at higher risk for SARC in the brain or the spinal cord?
So small fiber neuropathy is grouped under neurosarcoidosis, but it's a little bit different than a lot of the other forms of neurosarcoid that we've talked about, in that we don't, if we do a biopsy, we don't see those granulomas that Dr. Khatri is talking about. And we would see those granulomas in other types of neurosarcoidosis. So it's a small fiber neuropathy, we think, is related to buildup of just inflammatory signaling molecules called cytokines that build up around the small fiber nerves and make them very, very sensitive. To look for small fiber neuropathy, to confirm that that's what it is, electrical tests called EMG nerve conduction study are not very helpful. The best test that we have would be a quantitative pseudomotor test. These are not done very often. More commonly, people have a skin biopsy to diagnose a small fiber neuropathy. Once it's diagnosed, it does not mean that someone has a higher risk of having brain or spinal cord involvement with their sarcoidosis, and they may not have any other manifestations of neurosarcoidosis. Some of the other things that we've talked about, the cranial neuropathies, the vision trouble, they may never have any of those things. So just because someone has a small fiber neuropathy, that doesn't mean that they'll have any other neuro involvement. In fact, most of the time people don't.
Great, thank you so much. Okay, so we're almost out of time. I want to make sure we stay on time. We have a couple more questions we can get through. So we do have a question, and this might have been for Dr. Cron because it is about an echocardiogram. So if somebody is not symptomatic with sarcoidosis, do you guys ever recommend getting additional heart screening like an echo?
So I can take a stab at it first. When I do have patients with cutaneous sarcoidosis, I always have them get an echocardiogram, see a pulmonologist, and see an ophthalmologist. Like, that's the basic that I do, just because, like I said, sarcoidosis will involve other organs. It might start in the skin, but there will be some other organ involvement, and we want to be proactive in diagnosing that as opposed to reactive. So I do send all my patients to a pulmonologist, an ophthalmologist, and they get an echo.
I have a similar approach, and additionally, the reason that I would want an echocardiogram is because it does influence treatment selection and treatment dosing. Dr. Khatri's warning slides that she showed, or the package inserts about the TNF alpha agents, they really shouldn't be used in people who have heart failure. And sometimes we don't know that unless we get an echocardiogram. So it's my routine as well to send a patient for an echocardiogram, whether they have any cardiac symptoms or not.
Great, thank you. Okay, so we have we actually got this question a number of times in the registration. It came up here in the live Q&A as well. And this is to each of you. Dr. Willis, I'll go to you first. What would you consider the length of time someone is asymptomatic for them to be in remission with sarcoidosis?
Mindy, that's kind of a trick question. Sometimes I can tell that people still have active sarcoidosis even when they're feeling well. For example, if someone has sarcoidosis in the brain or around the brain, sometimes I still see what looks like sarcoid activity even when someone is feeling much better and clinically they appear to be doing well on treatment. If the MRI looks really good and they've had brain and spinal cord involvement and that looks clear and the patient is feeling well and doing well, then at that point I would say that someone is in remission.
Great, thank you. Dr. Khatri.
So I think I'm a little fortunate because, it's easy to see sarcoidosis on the skin. And if they're all clear and if they don't have any other organ involvement because they've had that screening that I just talked about, then I will say that, hey, you're in remission because I can see that there's nothing on your skin. But then I also sort of give this caveat that just because you're in remission, I can't predict whether you'll stay in remission or what that step, that length of remission means. Could it be 3 months? Could it be 6 months? Could it be 5 years? And every patient is different. So just because you're in remission doesn't mean that you stop seeing your physician or stop being aware of any symptoms that can potentially suggest a recurrence of your sarcoidosis.
Great. Thank you guys so much. That actually ends our session. We're going to end right on time. So thank you to Dr. Willis, Dr. Khatri for these wonderful presentations and this really excellent Q&A session with you guys. It was really excellent to hear your expertise and have you share so much information with us. I will just share a little bit of information and post in the chat here. If I can find it. All my windows open. So as a reminder, we do really value everyone's feedback about our webinar. So please do complete the super quick survey for this webinar. For those of you who are using Zoom in a browser, it should automatically take you there once you leave the webinar. If you're not, it will be added into the chat here. And so please click on it to launch it before you close today. I also want to remind folks that we have more education and wellness webinars coming up in 2023. So you can sign up on stopsarcoidosis.org/events. And if you haven't already, please do join the FSR community to stay up to date on news, events, clinical trial opportunities. We're also excited to share new opportunities to get to make a difference in sarcoidosis space. We are currently looking for volunteer community outreach leaders and voluntary support group leaders to work with our 38 FSR Global Sarcoidosis Clinic Alliance members across the country, including Dr. Khatri and Dr. Willis's clinics and their health systems. So if you are interested in volunteering and you want to learn more and you want to make a difference in the sarcoidosis space, please do check that out. And all patients can take research into their own hands by joining the FSR patient registry, where your voice matters and helps us and researchers understand this disease. There's also still time left to participate in FSR's Stopping One Snowflake at a Time program. Together, we want to create a blizzard too. So we hope you'll join us in raising awareness or sharing your snowflake story by participating in our year-end fundraising. To learn more about that, you can go to Stop Sarcoidosis, One Snowflake at a Time. And again, I will add all of these links in the chat, and you guys will all get this recording in your email probably tomorrow, usually within 48 hours. And we will see you all later and have a really wonderful evening. Thank you so much to everybody for coming. And thank you to our experts for sharing their vast experience and knowledge.
Thank you for doing this, Mindy. This is great.
Good night, everyone. Thank you so much.
Good night. Thank you.